Hello, my name is Natasha Sheybani, and today I'll be sharing with you our findings on the use of focused ultrasound and gemcitabine for adaptive immune control of breast cancer. Our study is motivated by the global burden of metastatic breast cancer, which has a 5-year survival rate of just 22% and remains incurable to date. Though spontaneous immune rejection has been documented in breast tumors, immune eradication remains rare owing to the persistence of immunosuppressive networks and poor T-cell infiltration in these tumors. To this end, the study I will discuss today utilizes the murine 4T1 model of triple-negative breast cancer with the goal of understanding whether thermally ablative focused ultrasound is capable of invoking immune sensitization in this setting. In this model, we explored FUS partial thermal ablation using a custom-built 3 MHz ultrasound-guided FUS system, as pictured here. This schematic rendering shows our ablation scheme, and through H&E staining, we were able to confirm successful ablation. 1 week following ablation, we observed that the frequency of both dendritic cells, as well as their mature or CD86 positive subset, was increased in the draining axillary lymph nodes of 4T1-bearing mice, suggesting that FUS may be promoting maturation or trafficking of these cells in the draining lymph nodes. Under the supposition that these dendritic cells may be encountering and activating T cells, we also evaluated T cells at this time point. However, we did not observe changes in the T cell compartment of tumors or draining lymph nodes following FUS. In probing the 4T1 immune milieu more deeply, we noticed that there was an immunosuppressive barrier conferred by myeloid-derived suppressor cells, or MDSCS. To counter this, we utilized gemcitabine, a myeloreductive chemotherapy that's been shown to attenuate the MDSC burden in 4T1. And we postulated that combinatorial therapy with gemcitabine will elicit a more robust T cell response to FUS. We implemented a paradigm involving 3 weekly doses of gemcitabine, initiated concomitant with a single session of FUS. As depicted here, we observed that combinatorial therapy significantly constrained primary 4T1 outgrowth and also markedly improved overall survival relative to monotherapy or sham counterparts. And in order to probe the mechanistic underpinnings of this protection further, we next evaluated our combinatorial paradigm in RAG1 knockout mice, which lack mature T and B cells. Across primary tumor outgrowth, as well as survival, we confirmed complete loss of FUS+GEM-mediated protection in the absence of an intact adaptive immune compartment, suggesting that T and or B cells may be playing a critical role in this paradigm. To implicate a role for T cells more definitively, we next depleted CD8 positive and CD4 positive T cells on a FUS+GEM background. And here you can again see that across both outgrowth as well as survival, FUS+GEM-mediated protection was lost in the absence of T cells, suggesting their critical role in this paradigm. To close, I'll briefly highlight that we've also evaluated the response elaborated by this combinatorial paradigm when combined with PD-1 blockade. As you can appreciate from the growth curves shown here, neoadjuvant priming with anti-PD-1 therapy can serve to further improve the constriction of 4T1 tumors conferred by FUS+GEM. And this suggests that application of FUS in the presence of GEM may be able to sensitize these otherwise unresponsive tumors to PD-1 blockade. So in summary, combination of focused ultrasound with gemcitabine is a promising strategy for metastatic breast cancer therapy. We've shown that the protection offered by this combination depends on adaptive immunity, and more specifically T cells. And we've also shown that this has the potential to sensitize murine breast tumors to PD-1 blockade. I was unable to share today that we've also generated some data recapitulating these findings on a clinically relevant FUS system, the Thoracion Echo Pulse, which is also being utilized in multiple FUS immunotherapy trials at UVA. So I'm thrilled to share that this work motivated the development of a new clinical trial at UVA that will be evaluating thermally ablative FUS and gemcitabine in breast cancer patients. And this trial is currently pending approval. To close, I'd like to thank my former PhD advisor, Dr. Richard Price, and all of the key contributors to this work whose names are in bold. Special thanks to Drs. Timothy Bullock and Alexandra Witter for their collaboration on the design and execution of these studies, as well as Drs. Patrick Dillon and David Brennan for their invaluable insights in partnership and clinical translation. And thank you to our funding sources, as well as all of you for your attention.